So that's. They know my voice. That's fine. It's the same data set. Good afternoon, everybody.
That's definitely the challenge.
Good afternoon, everybody. I'm going to get started. It is my pleasure today to introduce today's medicine grand round speaker, Dr. Amy Sitapati. Dr. Sitapati serves as a clinical professor of medicine at UCSD, as well as the interim chief and chair of the Hospital Department of Biomedical Informatics, and the UCSD Health System Chief Medical Information Officer for Population Health. She serves as a site PI for the All of Us research program, which many of you have probably heard about, an initiative that aims to understand why people get sick or stay healthy by collecting longitudinal health information from huge numbers of people. Dr. Sitapati seeks opportunities to align people, process, and technology to deliver data-powered health. She's board certified in clinical informatics and internal medicine, certified as a lean expert with undergraduate training as a biomedical engineer and master's level training in both clinical research and business administration. So a very broad background that brings together lots of different skills. She's nationally and internationally recognized for her expertise in transforming real-world health through AI, personalized medicine, registries, vital records, and quality informatics. She has a strong publication record with a strong citation index, HSX of 21, is heavily involved in teaching activities ranging from graduate medical education to mentoring students at various levels. Her dedication is recognized by multiple accolades that she has received, which include the Lawrence S. Friedman Endowed Chair, 2024 Become a Merit in Authorship Award, and multiple 5-star physician inpatient experience awards, which is pretty amazing given all the many hats that she wears. So welcome, Dr. Sitapati. We look forward to your presentation on advancing human health through real-world implementation of population health, informatics, and intelligence.
All right. Yeah, great to meet you all of you. Okay. So remember, you want your CME. So make sure you claim it, and then I'll show you again at the end. And today we are going to talk about human health and looking at this in real world implementation through population health, informatics, and intelligence, kind of evolving stories here. So this is me, and thank you, Dr. Borja, for sharing some of the roles that I have. You know, it is such a privilege to be here. I've been at UC San Diego for more than 20 years and never giving grand rounds. And so, Dr. Bork, thank you for the great invitation to do this. And actually, I feel like I'm more nervous than giving grand rounds at some other institution somewhere because I know many of you. And I have such gratitude for all the work and collaboration with many of you. So I do have some disclosures to share. Some of these are feeling more service oriented in my role for the FDA as well as at the state level around equity. And then I serve as an advisor for many nonprofit organizations and public organizations, as well as I have a new co-chair appointment for the Epic Cosmos Governing Council, for those of you that'll seek some wayfinding after this. So our learning objectives today are to review clinical informatics, population health, and AI. And many people ask, what is informatics? I hope at the end of this, you'll have something you can say. I'll talk to you about the role of EHRs in data exchange. I think for the longest time, people used to think of us as like somehow having this big pile of electronic health records in a closet somewhere to help everyone. They said, aren't you the people with the data? Don't you have all the EHR data? I'm going to talk to you about where we are today and how to think about that, and how to think about digital health intelligence to advance health outcomes, and then the new challenges that are perplexing to us, including things about risk and ethics. All right. So first thing I want to do is really share my appreciation and gratitude for Dr. Larry Friedman. And Larry was my mentor, he was my sponsor, and he left an endowment for me to continue on this work. And one might say, well, hey, you were doing a lot of population health work. How did that change your perspective? It absolutely did, because every day I wake up and say, what would have Larry done today? How would he have thought about his community, his state, his world? How would he have advanced population health? How would he think about people who aren't in the room to get the best health and improve equitable health outcomes? So that's how I wake up, and I have such gratitude for his family and friends. All right, so today we're going to go through where we started, how we scaled, and then the use and incorporation of AI, where that's going, and then move again into this equity space. And I have some ethics questions for you to think about. So where we started, maybe some of you started on the same kind of keyboard. There was this huge computer with a little screen, green kind of key, like as you keyed, you'd see the prints there. And many people were doing pioneering work quite a long time ago. So this is our faculty, Dr. Rob Greinings, he's an adjunct, and he was working in 1966 with Octo Barnett, and in Mass General, they deployed the first system that he had helped to construct. And a really cool thing about it is multiple people could work in a record at the same time, and the database was made for healthcare. So this was really cool. It was called MUMPS, but later MUMPS became Cache, and guess what? That's what Epic is built on. So you can kind of say that Epic was built off the database that our faculty member helped to construct. Kind of interesting. Now, we all know that there's a critical absence of information at the right time, and a lot of times this is leading to harm. This is still a very important problem in all of healthcare. But people started thinking about this long ago in paper days, and many of you might not know that Dr. Larry Weed was one of our early pioneers in informatics. And for those of you clinicians in the room, the SOAP note was invented by Larry. Now remember, Larry Weed was not just the inventor of the SOAP note, he was all about implementation. So if you go on the web and look up for the YouTubes, you can see him across the country making these speeches to try to get a SOAP note. He said, we don't even have the information. What was your diagnosis? What was your critical thinking? What were your exam findings? There was nothing. So he pioneered that. If we move forward, though, more contemporary and more to UC San Diego, in 1983, Chris Matthews, one of my mentors, founded the UCSD Owen Clinic. It subsequently became one of the busiest HIV practices in the state. And he has this quote out on KPBS. When I think about it now, it's incredible. Back in those days, there was no internet, there were no journals about this, there was no name for the disease. And so that's where we started part of our healthcare journey, right? In informatics. And this is where my story began. And today I'm going to share with you my story as we see informatics evolving. So as mentioned, I was an engineer in undergrad, and I worked in a lab, the Merit Lab. I was studying titanium 6-4, threading corrosion, dental implant with pipettes and antibody, detection. And then I think I was one of the early people to actually catch a macrophage walking across a piece of metal on an SEM machine. That was a summer project. So I really liked science, but I felt very isolated. I was working in a lab, I wasn't working with patients, and I made a pivot to go to medical school. I certainly didn't understand how ABCD worked. I knew that every problem had a solution and it could be built. So I was definitely different. In 2002, I was hired at UC San Diego at the Owen Clinic. And this is where I started my clinical journey. I was working there, taking care of patients living with HIV. And subsequently, I was also working at the border at San Ysidro and provided almost a decade of border care. So I got to see a lot of persons with really complicated health. And you can bet the coolest part is information was really important to advance their health. At that time in 2009, I was working with Dr. Pichai. He invited me, hey, you want to do the science research? We have a chart review with an IRB. And so we had stacks of charts that had to come out of the archive to do the research, right? And page by page, these decks of charts you would look through to have a finding. And so this was published, but it also changed how I thought about things. So one of my patients who had been assaulted based on some of their sexual orientation subsequently got cryptococcus. And they were in and out of the hospital with this large, you can see edema around the cryptococcoma. And the patient was getting decks and back out in the hospital, back out into the ICU, back out. The patient wasn't going to survive the process. They weren't waking up anymore. So I had this idea looking through all the literature to utilize adalimumab. Of course, I got consent from the family who was able to look at this. And we utilized this. You can see the reduction in edema on that large mass. And so what I had learned from that previous got me thinking about innovation and the application of science in the real world. It saved a life. So about that time too, we were thinking about systems, and the Owen Clinic always had systems to track all the viral load of medications people have been on. It was critical to make future decisions. And so I was given the task, hey, map all that data. There's allergies, there's meds, there's viral loads. Put it all in the new system. We need somebody, Sitapati, you can do it. So I scrolled through month after month, spreadsheet after spreadsheet. And this is where I really learned the first layer of informatics, which is all about terminology. In 2010, I received this first award from CHRP, which was really the kickstart to do the work. And I tell you all this because some of you on the line are wondering, can I be a researcher? Can I be working in informatics? And I would say absolutely yes. So tuberculosis screening. I was working under Angela Socha. I was given the task, hey, make sure all your patients are screened for tuberculosis. As you know, as a border community, persons living with HIV, very high risk for poor outcomes. And so I couldn't, I realized doing all this analysis, the real problem was there weren't the right orders, the orders needed in the system. So one by one, a person would open the chart, type in the MRN, put in the order for a test. And we put in 1,200 tests, one by one, 20 hours of work. Now, I knew something was different because nobody cared about TV. I kept saying, do it, no one would do it. I got this. And I was like, what's happening? Sitapati, I went to the front. A patient was irate at the front desk saying, hey, I got this lab result back. It shows I have tuberculosis. Somebody's got to come out. I'm going to die. And I was like, wow, I'm so excited. I can't believe people are caring about their TV screening. This is great. We realized the old way we monitored things, which every clinician was getting the result back, was not a systemic, safe method. We needed to go back and check all of those abnormal results. So we ran 65 or so patients with abnormal results, reached out to every single one of them, tracked them down. One person had active pulmonary TB. So there's another life saved, we could say. This sparked curiosity in engineering health. And that's what I'm going to talk to you next about, which is the population health component. So engineering these things, we can do things differently. This is bulk orders. So I'll call this N equals 1,000. And what we were doing is literally thinking about cohorts, diabetes, hypertension, cardiovascular disease, pancreatic cancer, you name the disease, we were building the cohort, but building it in the system where the patients got the care. And then what that meant is we could decide to find the patient that didn't get follow-up, the patient that needed a lab test, all of those things, the patient with an abnormal test result. And we started ordering in bulk. It is such a thrill to, in 30 seconds, put in an order for 1,200 people, 1,500 people, 3,000 people. That is now you're saying 20 hours of work, 40 hours of work gone in a couple of clicks. So it's really systematizing the care that we want to deliver. And this, working with Barbara Berkovich, this is 10 years ago. This is the work that really got laid in for UC San Diego as part of value-based care. we were on the cutting edge doing this work with others, and we invited collaborators. You can see it was everything from who are the patients, who takes care of them, how do we engage them, what are the types of disease management markers that we want, and how are we measuring those outcomes? What is the 360 feedback loop? So this is a lot of data and systems. These are, now 100, 200 registries. Some of these have, over 1,000 metrics in them. So massive Lego pieces. And what we were seeing is if we came up with this way of engineering health, we can push outcomes. So in 2018, I hope what you can see is that you put your eye on the ball, you engineer the health, and you can up level. So what you're seeing on the left under behavioral health, ambulatory, primary care, specialty, and Million Hearts is where our performance was at period A, and then moving across a year to a target goal. And I hope what you can see, we call this get to green, is that if you set a goal, you put the process in place, look how many green, you can up level the care. Now, it was really disappointing to me because I think about Six Sigma from a lean perspective. And I hope you can see here, you're like, what? 89%, is that good? 61%, is that good? Well, I can tell you, continuing to move these curves up is the challenge. That's what we have to do in healthcare. Primary prevention, secondary prevention, and we're all about it. And this is the team, Jennifer Holland, Tracy McGee, Heather Irwin, Chad Van Hoover, working with hundreds of clinicians to push these 80 measures across. But we were learning at that time that there were also disparities in health. So if we did different dimensions and looked from an equity lens, we could see that people who identified from race or ethnicity, differences in how their performance, and sometimes they were statistically significant differences. And we learned that if we actually target the resources to help the persons who have those disparities, we can often close those gaps. All of you might think tobacco is such a boring thing, but it's still a #1 predictor in cancer, COPD, cardiovascular health. And every day we're interacting with people, we don't ask them, do you smoke? And then if they say yes, we don't do something about it, right? So this is just one of those things. And today we utilize bulk ordering. We also integrate with the state. And this is part of Project Moonshot that we do with our cancer center. Now, Parag Agnihotri, our CMO, and this is 2023, was very interested in thinking across UCs, and he's been leading us in that direction. One thing I want to show you is over here. So we're the orange.
This one, the mouse profile.
Oh, okay. So we're orange over here. And then you can see on the far left, the pink box shows UC San Diego went to the top. We became #1 for the UCs. Well, behind this work is a whole lot that happens. There's a digital part of it. There's alignment of quality committees. There is a lot that actually enables this. But this is one of the pieces you might not have known about. This is a 2020 conversation. So Justin Bowell, one of our PharmDs, leads a team that interacts with the patient between visit. How many times have you seen a patient comes in and the systolic blood pressure is over 160 and hope someone follows up on that or they come back soon, Well, this is systemically reaching out, taking those outliers and engaging with them, whether telephonically, whether digitally. And here you see the conversation. So you can close that gap shortly and identify the real problems that are happening with the patient. They love this. But there's still disparities. Okay, so we come back, we learned there were disparities in some dimensions. This is one of the UC reports from our UC data warehouse. And you can see for Black and African Americans, there's actually worse control. So there's a disparity that's present when we look from that dimension. And if we look nationally, there's worse cardiovascular outcomes at a national level. This tracks, it makes sense. So could you actually make a difference? In 2021, we deployed a program to preferentially also make sure that those patients were engaged with. We assess their barriers, we address any social determinants, and apply nursing and pharmacists as makes sense, tailored to the patient's needs. And so here are some of the tactics that we used on the left. I hope what you can see is the gap closed. So if you think about it from structural barriers that affect our patients, if you reach out and systematically close those gaps, you can actually make a difference in the health disparities. However, if you relieve, take away the things that are utilized to make that difference, you can see what happens when the pilot ended and all of those extra resources were not, prioritized to do that work. You're back where you started. So this would ask us to think about how we address structural barriers for our patients in systematic ways that help to truly address persons with health disparities. Now, not just were we thinking about inside the clinic, ambulatory care between visits, we are also very interested in what's going on in the hospital. And this is work with Tom Moe. One of the things we were thinking about is, could we better, at the point of care delivery, help inpatients who are having surgery? So this is emergent general surgery. First of all, could we figure out who those patients are who have emergent general surgery? And then could we actually every day run a list and find out, the NPO too long, DVT prophylaxis was held. We all know that ORs get busy, patients get held, there's prolonged, NPO status, and this leads to other harms. So this is the report that was developed, and automation was started from this perspective in our surgical using registry cohorts. Now, many of you know there's all kind of other problems in healthcare that need engineered solutions. And this is one, SureNet. So SureNet is this idea that diagnostic harm, we know something's out of whack, but we need to go chase it down. It doesn't happen. And pulmonary nodules end up becoming cancer for a subset of patients. And sometimes we lose it, right? There was a chest x-ray, the patient came in with bronchitis. They don't have pneumonia, but they have a nodule that needs followed up. This is the problem we were trying to solve. So working with George Chang, Rajit Suri, and Rob Alcara, we were trying to design what could this look like in a systematic fashion to break down these barriers. And the cool part is, not only is it multidisciplinary across departments in the real world, it also has AI built into it, which is really super lovely. So what you can see, if you're trying to break this down and you're trying to build a SureNet solution, what's the problem you're trying to solve? What's the guideline you're going to go to? What's the workflow of the people who are going to make a difference in the health outcome? What's the technology that's supporting you? And then how are you having a data-driven workflow? So this one in pulmonary nodules, we know it's a problem with new cases of lung cancer. We use this Fleischner guidelines to help us review. And then of course, our experts helped us determine exactly where to put those cut points on the engineering side of our system. But on the right side, I hope what you can see is this radiology intelligence was a part of the solution. So it was systematically, of course, the radiology attending was reading the film, but also the AI was reading the film. The AI does little nudge, hey, guess what? There's these two at this coordinate, this exact size. We can actually drop some of that information straight into the registry that's within the health delivery so that we can have longitudinal tracking of size of nodules. Because remember, it's a one to many, so it's actually a really stubborn problem. One human, multiple nodules. But the magic is not just it falls into a real registry, it's that humans are designed to actually get prioritize the most difficult patient first. So sometimes that means the one that was biggest. Sometimes it means the one that hasn't been followed up in the longest amount of time. Sometimes it means the fastest growing nodule. But this is the workflow that's in place. And already within the first month of launch, of course, lung cancer was discovered from people on these lists, right? So this is one way to improve the health delivery. Now, I've been talking about population health, but population health sits very close to public health. And there's lots of thorny issues there too. So I've been asking myself a long time, everyone talks about value-based care, nobody knows if the patient's alive. And I just think that's unacceptable at a state level, at a national level, and definitely at a local level. And so I said, well, I think we can actually match that file in. We can use some informatics to do the work because it's problems we want to solve. Did our patients who had surgery, did they survive? What about we're reaching out to patients to ask them to come back? Did we want to actually message the family after the patient is deceased? So there's all kinds of things that come up. Could we actually match it? Well, as best I know, not too many people were thinking of doing this. So what I did first was actually map, and here you can see, what would this registry look like? What would all the fields look like? What are all the data types? How would you organize it? And then I hope what you can see is that you can take external registries, pump them in, map them with your electronic health record, and basically push them right into the front of the workflow where it makes sense. So today, when persons with transplant are making phone calls out, we don't wipe the record and lock it as decedent. Instead, we say, hey, you know, it looks like this person might be expired. Please be careful if you're going to call this patient, right? So there's ways to think smart about the workflow. When we did this work, we found that we could match 102,000 persons without an SSN who were alive in our record, but weren't alive. So it's a really important maneuver to actually sort of clean up. Now we do this on a monthly basis. We have standard procedures to actually ingest, map, and put this into the workflows that matter the most. But there's a gap because this managed our local problem, but this doesn't manage the rest of the problem at a state and national level. And this is an authorship by Mike Hogarth working with Neil Wenger. And I hope what you can see, this was their health system outreach from UCLA after the patient had already been expired. So they were making the point, there's still lots of work to do in this space at a public health level that informs also our health system outcomes. So if data sharing is so critical in health, how do we do it? And what about this vital record space? So others have been thinking about this a long time, and Chuck Jaffe has been working with us in our division and department, giving a lot of advisement around how to think about interoperability, and is a robust teacher for our trainees. HL7 was founded in 1987 and really sets the standard for how we think about health level data exchange. And some of the newer adaptations of that, for those of you that would get quizzed on informatics after, are called Fast Healthcare Interoperability Resources, FHIR. And so what this means is an ability to better exchange data between entities. So we thought, wow, if there's this infrastructure and it's there, how could we utilize this to advance some of the vital record space? Now, other people have been doing this, looking at least Smart on FHIR and FHIR-enabled applications and seeing what's possible both for clinical care and research. And it looks like, according to some papers, well, maybe there's promise in doing it. So we picked up this idea, and for the California Integrated Vital Records component, we were thinking, how does this translate to a local environment? So this is Vera Donat-Bott and Ed Bean, and we were working together to explore the feasibility of EHR retrieval, putting hooks into the EHR, extracting what's required at a jurisdictional level to go to public health. And so when we tried to do that, we found out that the electronic health record has very rich birth data. And I just put like a little clip on the side, and you're going to see, whoa, that looks like informatics stuff, because what you can see, there's a PDF output that includes some of our terminology. That includes things like SNOMED, but it also includes here, you can see how it gets parsed out, and this is called a JSON file. So, but what I hope you can take away is there's very important data that is possible to find in this, but it doesn't look easy. Like you just hook up and like kind of understand exactly what that data is saying. And I think for all of you, so we found, hey, there's still a lot of work to do to map and parse the data to make it relevant when you're thinking about this public informatics level. But still super cool. All right, so I think I talked to you, we're working our way up. You know, we talked about the manual 1,200 orders, then we went to like 1,000, then now we're at 10,000. What about dashboards? Okay, so engineering dashboards is something that Chris Longhurst and our population health team have been doing for some time. And they are trying to have real world implementation. In fact, the Joan and Irwin Jacobs Center for Health Innovation has been a critical infrastructure for up-leveling the kind of work that is possible. And I would say every health system would benefit from having something like this. This is an enabler that allows new innovation to better hit the real world. And this is what one of those dashboards looks like. So this is from 2025. Again, thousands of patients. Think of it like there's airplanes coming in and off, but someone is managing the patients between visits to see what's going on with them. We have on the right glucose, so glucose in the middle, blood pressure, and on the far left, more mental health services. And so patients have digital engagement in these programs, values are shared, but they're live people supporting the actual work to check in on the patient. So I hope you can see here, this was my biggest worry. Type in the data on a digital device, now you got 50 values, and what if one's 200? Who's actually checking that the patient's okay? So this comes in, it's on a dashboard, and RN sits over it. All crisis-oriented ones get outreach that are prioritized, just like a nurse who is sitting on a unit. And so this is how we have improved our blood pressure. You saw that number one spot. It's because we're integrating data and we're tackling the blood pressure as it's not controlled along the way. But meanwhile, while all of these great digital things are happening, doctors and clinicians are having increased messages. And this is more work than meets the eye. Every time I look at it, I'm like, it possibly couldn't get to be a bigger number. And there's a bigger number. The inbox just keeps totaling up, and you can flush it out and it's 90 again. So this has to be one of the underlying factors when we think at a national level about burnout issues. And so how does health AI help to address problems around this abundance of work? So this is Ming's paper. Some of you have read this. So last night I was working in my inbox. I was answering patient questions back. What happens is AI prompts, here's what the patient, you could start this and answer back to them. And then I can go in and edit what that response looks like. So Ming Tai Seal led the paper that was published in Open JAMA. And what we learned is, guess what? It's not saving clinicians time. Yeah. So we're still spending plenty of time. I can tell you, I still love it because I don't miss something. The patient had a little left shoulder pain. That's not shoulder pain. That's cardiac pain. The first month I used this, my patient told me, oh yeah, by the way, when I was walking up the hill, I had left shoulder pain, but if you could refill my antibiotic and blah, blah, blah. And 1 month later, the patient was in the cath lab and had their coronary opened up. Yep. So if we weren't saving time, what else could we do? This is work with Grace. So Grace Hugh is one of our graduate students in the BMI track. And one of the problems we were trying to solve is there's lots of work happening. So we were trying to estimate which patients are taking all of our time in primary care. And let's look at it, not the doctor's time, everybody's time. Let's try to estimate the nurse time. Let's try to estimate not just the face-to-face, but all the extras, the phone calls that come in, the MyChart messages, the request for orders. Let's get those all totaled up and see if we can identify who are patients spending most of our time. I think the most astonishing thing was just for our health system, there were over 1 million encounters in a year. It's a lot of work. If you did an estimate of what that work might be, it would be more than 96,000 hours of time. who is spending all that time? It's no surprise that there's pajama time. So what we were curious about though, if we developed a risk score to allow patients, and that's what you're seeing here. So you see, this is again, the problem we're trying to solve is who is utilizing our team time. So you see in green box, low risk, this means the average consumption. Maybe it's a physical, or maybe it's a physical and a follow-up visit and a couple of my charts. Then we have the yellow box, which is high risk. They're going to use more time. And then there's the red box, which is the highest risk. Okay, that means they're going to consume more minutes. And I can do a whole talk just on this modeling. But the point I wanted to make here is we took a different angle. So this is Healthy Places Index, which is a social vulnerability index. What it tells us, when you see the 0 to 10 on here, then what you're seeing is the patients who have the least health in their community. They're lacking transportation, healthcare delivery, food. They have more persons living in their house. And so if we go to the lowest quartile, is it a surprise that we see the people who are predicted to need the most of our time also have the least health in their community to offer? It's not, right? And so what does this mean? Well, this means when we go to engineer the solution, do not cut the time. Think about how to do the time smarter. Okay? What I mean by this, when I say don't cut the time, what I'm actually trying to say, did they need 20 MyChart messages and 4 telephone calls and, all of this? Should they have actually had a non-face-to-face that was virtual with a nurse practitioner in preparation? Did they need more coordination of their care between the visit? And so Joe Diaz, who's here with us, has been helping us think through how do we actually acknowledge that persons like this may need the care and get them the right care rather than just the care as it's ad hoc happening. Okay, so now I'm going to pivot to a different area, which is the outcomes, equity, and ethics. And what are the challenges that are unfolding in this environment that we have? So first of all, informatics is a critical backbone of health disparities. And this is an article co-authored by American Heart Association, just outlining some examples of the racial disparities. And I can tell you, for those of you who haven't looked at outcomes post-COVID for Indigenous peoples and seeing, what those life expectancy curves look like, I encourage you to go take a look. So one part is being informed about what the health disparities are in your local and national environment so that you know how to approach problems as they come. But another part is having the data. And so people for a long time have actually lacked having data that's built to standards and culturally inclusive. And who's collecting that data and how are they interacting with the patient on the other side? So some of those are more familiar, so I call them the real for those of you who haven't heard these terms: race, ethnicity, and language. Some are SOGI, sexual orientation, gender identity. Some are SDOH related, that's the social determinants of health. But you can see there's a whole list, and there's new sensitive data that has an impact as well, such as your residency status or reproductive health services. And this is probing new questions. Wait, were those exactly on the PHI? What do we do about those types of data? Now, one part is how you collect the data. To get good data, there's two pieces. One is, I hope the patient can help inform, because many of these are patient reported, and patients should be entering their own data where possible when it comes to some of these around what I call the Jedi terms. So here you can see, and I hope you're looking at it thinking, I wonder how they got this list, which is number 2. How is this mapped on the back end to standards provided by the CDC and HL7 Fire in what are national standards so that this information, when it's applicable and appropriate, can be exchanged? So again, part of it is patient collected. Another part of it is adhering to those national standards. But we know one part of it is getting the data, the other part is, hey, if we're gonna do a lot of outreach and technology to engage with digital ways to our patients, not everybody has access in the same way to the technology. And people brought this up to me all the time. Hey, Sitapati, you're primary care, you're super into tech. What about all those people? They don't have insurance. There's a digital divide, they don't have broadband, right? And I say this, like, really the technology takes a group of people who are able to serve themselves and allows them the access and the technology to do it. So they're always going to be people, they're sight impaired, they're hearing impaired, they're maybe not having digital broadband access. We need a path for them too. But we don't need to give our most precious human resources to people who can actually take care of themselves without it, or at least supplement part of that. So when you design for many users. Now, we're building ecosystems to get a lens at what's going on in our quality spaces. And I won't forget the first time I looked at these kind of outputs, it was COVID times. And what I saw was that persons based on race or ethnicity had a less chance of walking out the front door if they were in the ICU with COVID. And I thought to myself, wow, how do we get more of the health disparities in the viewpoint of others? So one standard that you can see here on the very right side is, again, having different perspectives to look at cohorts. So this is a master view, but you can imagine for thousands of boards having drill down to look at different health disparities for standard quality metrics. Now, we were curious, data's data, but data becomes fun when you actually make a difference in people's lives. Jijo Kula actually helped us look at this. So one of the ideas we had when we got the message, hey, guess what? You have the first tickets for COVID vaccination. We all thought together, the patients that are in our hospital, they don't always have the same resources if we think from that community perspective. So we took people with the lowest Healthy Places Index, meaning their community was least likely to support them, and put them first in line to get ticket. Telephone call plus my chart message, reach out first. And this actually shows the comparison, this curve down here, Petco versus UCSD. The higher curve of pink on Petco is standard what the county did in terms of its outreach with digital engagement. I hope what you can see, because it's further up on the left, like it's kind of pointy to the left, it's higher on the leftmost, is that people with better health in their communities, better transportation, lower volume of persons in the home, higher income, were better accessing the vaccine as it's made available. And so you can engineer to try to mitigate some of that, which is what this shows with the blue curve. Now, we went through engineering at 10,000, but we're trying to get bigger. So now this is the engineering tool of 9 million. Okay, so this is a democratization of data. And I wanted to share this with you because all of you who are UC San Diego persons in health can have access to the UC data warehouse. And this is a view of that 9 million persons and growing of the cross UC. And what's really cool about it is if you have data science skills, you can get in and ask questions with pre-mapped data. So those of us that are informatics oriented people have already organized a lot of the data into OMOP tables. And so this is truly a democratization of data because you can go in and ask health questions for yourself. Now, the tools are getting bigger. And so the next one I want to tell you about is N equals 300 million, okay? And this one comes to us from the Cosmos structure. So currently today, there's more than 300 million patients in this data asset across the US. And for those of you who have a health account, you can request Cosmos access. And for those of you that know Slicer Dicer, it's a self-service model. You can use a Slicer Dicer over this Cosmos data set to ask questions. This is like a never been had before, that someone with no data science background could get into a tool with 300 million lives and ask questions. And there's plenty of things that are just ready to be solved with this. Now, for those of you that want the data science view, that's different. There is a data science view to this that requires additional training and cost. But as we think about scaling all of this data, there's notes in the background, whether you're talking locally or else, I have new questions to ask, and this gets into the ethics component. So think about this, unstructured data notes can be interpreted now with generative AI, so you can use large language models to read the note and extract and find things. So look at this. This is an artificial note, the last little asterisk, patient has been displaced and seeking asylum due to being transgender. How do we feel about this if this was marked de-identified data set? What does that mean? But wait, it's notes, so it's going to be a limited data set. But wait, like what if we could see this in the record? Is there risk for harm? And a lot is going on in our world, so I just point these out. This is from Wired. ICE is getting unprecedented access to Medicaid data. If you haven't seen this, take a look at this article. And then here's another one. California approves bill allowing providers to omit names of patients for reproductive rights bottles of medication. So again, what are the new risks with some of these dimensions of data that we haven't thought about that are being scaled at hundreds of millions of lives? What do we do with this kind of sensitive data? This is a really important question that I'm asking at a national level. So that was the n equals 300, but I'm going to laser back to an n of 1. And I think new on the horizon too is how do we engineer tools for the future that help personalized medicine really happen? And people have been thinking about this a long time. So this is another mentor, Lucila Machado, and she's been thinking about the ethics and ownership and permissions revocable with subcomponents of data sharing on a platform that helps improve the security around what's being offered. And as we think about this, we still get into the same pickle. We could have all kind of important data, but it's not all co-located to drive the care. So this is an article that's now almost 10 years old, not quite. And we can see that we still don't have, from a personalized medicine perspective, all the different data assets, but in the care delivery to help improve at the point of care decision making. And I think this is a critical gap. And as you can tell, much of the story today was a personal story with a lot of recognition for people who've advanced this work. But this is called N of 1 equals me. And so I've passed my 10-year mark as a HER2 breast cancer survivor. And I was curious, I wasn't a BRCA carrier, so I got external testing, both one in research and one in private. I got the pharmacogenomic testing and then polygenic risk scores, and I was curious about my results. So here it is, this is my test, and it said on the test, in bright red, share with your doctor. And I was like, oh, that's helpful in this PDF. And what I saw on this CYP2C19, which some of you may realize, this means Plavix isn't going to work for you. Okay, so I was like kind of going through my head. I'm a breast cancer survivor. I had chemo and radiation and surgery. I've increased cardiovascular risk from the radiation exposure. So like if all of a sudden I collapse with an MI and they put in things and they decide, hey, guess what? Plavix is what you should use. Well, there's a box warning on Plavix to make sure your doctor knows, but none of that is integrated into the workflow. So like we have to get back to, there is critical data. I've had these tests, I'd love to share them into my record. They should be driving decision support off dosing, but also there's other pieces that are missing about my increased risk as a breast cancer survivor for things people should think about if I collapse and show up at the emergency room. And this is personalized medicine. This is where we will be going, but think about all of these N of 1s merging in with all of the knowledge. It's just super cool. Okay, so I want to thank a lot of my mentors and contributors. But I really think we stand on giants. None of this work is possible. Hundreds and hundreds of people have contributed to the stuff you saw today. I mean, I would easily say maybe even thousands of people have helped to generate the work you saw. And it's the talent, inspiration, and innovation that really impacts human health. But I have to end with something from my mentor, Larry Friedman: skate to where the puck is going. All of you can make a difference in healthcare by innovating in new ways. All right, so with that, I want to share my gratitude to the Larry Friedman family, and I want to take questions, but I also want to make sure if you need to claim your CME, do it.
Questions?
Yeah.
You have something online. This from Stephen Seltzer: facing 3.5 years of a federal administration hostile to DEI, reducing funding for research, public and international health, are you developing a strategy to salvage some of your efforts?
Okay, what a great question. Yeah, so people ask me, hey, what are you gonna do in the current environment? You seem pretty DEI oriented. I say, make sure first to do no harm by your community and patients. So think about the lens first of the people you want to help. Make sure what you expose is not putting them in harm's way. Second, who else do you work with that you might want to say, well, hey, like they don't need this exposure. But personally, I still do the same work in the same way. It's been a life commitment to border care and diverse persons having access to care. And that hasn't changed. I think how we speak about it, how we maybe publicly post some of it, the avenues for funding may shift. It's still the same care many of us have been providing for decades.
Thank you, Dr. I have a question that is about scaling. And the reason I'm asking this is because you really took us through the scaling from any folks all the way to 300 million. I don't recall the number. My question is, anytime somebody has scaled anything, there comes a point where they, oops, my first step somewhere there, I should have thought this through, because now it's not scalable because of some intricate step at the very basal foundation that was not there. So in scaling, was this modular scaling where you can go fit just a module and try to adapt as it goes? How did scaling work in this case? And what potentially does this mega giant last thing that you showed, the 300 million scale level, what data there is possible to just put it in by using a more modular approach rather than something at the very base, something that needs to be again tinkered with, because that's a loss of time. So how does one scale things like this? Modular, pyramidal, how? And how did it happen? Do you think there were some things you would have done differently to make it better that would say, okay, scaling could have been done with a different thinking?
Yeah, I mean, I've thought for a long time, actually having national collaborators that agree on standards, terminology, and interpretation. And I think this question on scaling really does come down to our professional societies, whether you're talking about pulmonary or cardiovascular, not just to pump out guidelines, but to interpret these into digital platform enabled vision. And what I mean by that is, like, someone has to take whatever guideline, convert it into some kind of measurement of quality and outcome, but there's terminology behind it. And do it once, print it, mint it at a national level, and then allow the adopters, both whether they're, I think, corporate industry or local, to utilize the Sitapati blueprint. We don't need to each person be making a blueprint for care delivery. We should have a wiki system. It's like an ecosystem where people tackle different problems and share on a common terminology set. And I think informatics is right to do this.
So convergence through consensus.
Yeah.
Early on.
Early on.
Thank you.
Yeah.
You use the Healthy Places Index a lot, or a lot of these places papers utilize that index. I know there's a couple different large public health indexes or scores that exist. Is there something that is not measured collectively within, say, the population of California or San Diego that you would create an index for?
Ooh, well, I just want to congratulate the people who made the Healthy Places Index publicly available with downloadable files for anybody who wants. Are really just absolutely brilliant. And what I love about their work is it was census block oriented. It was not zip code, which means the fine tuning into the differences between an individual community could be further fine tuned so that people with differences that might be within a zip code that can be quite big could be represented and not just matched into a medium risk, right? You could actually see that. So I do think like at a national level, not having zip code but actually to census block, I think is a better measure. And then I do think that we also need to really step back and say, look, there's things that we can change and things that are kind of inherent to the location. So you could be in a rural part of the country that's 100 miles from a hospital. Like there's nothing you can do necessarily about that, but you can have a digital strategy around that delivery. And so I think kind of separating out also within something like this. So have a Healthy Places Index for the country, but have things you impact on different lanes with like a guidebook of like, okay, well, these things are, let's say healthcare access could be areas for policymakers to look at like coverage, but also could be opportunities to having partnerships for tele-remote kind of access.
Question when I come about is it going to be online? Okay, so well, one is just a comment from Dr. Longos. Tour de force, thank you for a fantastic grand round. An overview of DBMI at UC San Diego Health. And then from Jennifer Lowe, wonderful and inspirational presentation. Thank you. Please provide your thoughts on how one can use pop health or medical informatic tools for drug safety and women's health. Do you know of any existing efforts in this area?
Yeah, well, I think Jennifer's been a great partner from the School of Pharmacy, and I think one problem we're all trying to think about is how would we safely deliver medications at home? And many of you have seen more hospitalization at home. And today what happens is you get a fax 5 days later of what home health said. You get the lab result for a Banco level 10 days after the line was pulled. The safe monitoring is very holy in the moment. So one could imagine a digital system where everyone's digitally connected, the nurse that goes to the home, the patient and caregiver, and the doctor, and it's interfaced through into a resident workflow that makes sense for the applications people use. You can do this interconnectivity these days in ways that are much easier than past through APIs. And so one could imagine then you could do safe prescribing of meds that need safe monitoring at home through this digital application. And also pairing with the newest type of AI, I think AI and Bayesian methods together can actually help us with difficult med dosing and interpretation of missing levels. So there's a lot of basically math and measurement that can be up-leveled with artificial intelligence.
And again, from Stephen Salzer, do you think wealthier patients will be able to choose between having a human and or AI provider, and poorer patients will only have a non-human AI provider? Very provocative questions.
Yeah, well, I keep thinking, Stephen, thanks for the question. Currently, my stance is I'm worried that digital is expensive. And so people who are in regions that can invest in artificial intelligence or have access won't. And so their hospitals won't be smarter, so to speak. Their patients won't have all the digital assets. And I worry that there'll be a digital gap because of places that aren't AI enabled.
Okay, any other questions?
Okay, thank you.
No, thank you, Amy. That was